47-year-old male, 10th day post-subarachnoid hemorrhage. He also presented seizure on the 6th day. HIV positive without treatment or follow-up, and he's also a smoker. Neuro examination at the admission showed moderate headache, neck stiffness, no neurological deficit. Positive bilateral Babinski and Hoffman signs. This is 3D reconstruction of his CTA. This is AP view. So we have the left carotid artery, A1, M1, right carotid artery, M1, A1. So let's see. There is a rather big elongated aneurysm arising from the intercommunicating artery. So let's follow here on the left side. A1 going to, it will join A2, and then there is a trunk, actually it's the ACom over here. So A1 left, A1 view continues with the A2, but here we have a short trunk, which is beginning of the ACom on the left side. And we can see here the right ICA, A1, and then A1 will join ACom here, and they have, and this is A2, right A2. They don't have a common trunk on the right side. They are separate. You see, this is A1, this is exiting site of the A2. Whereas on the right side, A1 continues as A2, and there is a short trunk of ACom. This is a very important detail. We're going to show it in the surgery. And also this aneurysm on AP view is pointing downwards. Pointing downwards, it is located between the two optic nerves. So, and also the dome is pointing towards the left side. This is a superior view, S. So we are looking top down. Here is the right carotid artery, right A1, right A2, left ICA, left A1. We saw that it is continuous with A2, and then there's a trunk of, very short trunk of ACom. And then we can see that the dome is directed inferiorly and towards the left side. So my question is, should we approach from the right side, or should we approach the aneurysm from the left? No, let's show this short video of the 3D reconstruction of the CTA. Let's go to the video. Now we will turn slowly toward the right side. We have to pay attention to the exiting site of A2, and also basically we have to see 4 vessels. Right A1, right A2, left A1, left A2, and the projection of the aneurysm. So answering the question, should we approach the aneurysm from the right side or from the left? Since aneurysm is filled predominantly by the right side, right A1, and also the aneurysm is pointing downwards and towards the left side. If the aneurysm is pointing downwards, in surgery, it's very dangerous for you to reach and get the proximal control. For instance, if you want to approach from the right side, you will have A1 easily for proximal control, but you will not have left A1 for your proximal control because the aneurysm is in between you and the left A1. So you have to approach this kind of aneurysm pointing downwards through the side where the A1 fills the aneurysm. So this one is predominantly filled by the right A1. We should approach this aneurysm using, for instance, pterional approach, right pterional approach. Now the AP view, once again, you see this detail is very important. So we have decided to approach the aneurysm from the right side. And here should be the place where I should put the clip to close the aneurysm. So crossing over here, sparing A2, A1 from the right side, A1, A2, and also ACom from the left. So let's see the short video turning to the left now. Let's go to the video. Very important here. So she underwent right pterional approach. The Sylvan fissure has been opened already. So this is right MCA, this is right ICA, internal carotid artery. So let's go to the movie. And dissecting, sometimes the vessel can be attached. That instead of this one, for instance, belong to the temporal lobe, but it's stuck to the frontal, so we have to separate it. This is internal carotid artery, the right one, right, and this is M1, right M1. And then dissecting, this is the right A1. Now I'm following the right A1 because this is the artery that will predominantly fill the aneurysm. Now this is a right optic nerve, right carotid artery. I am dissecting, trying to separate the frontal lobe from the optic nerve, right optic nerve. Pretty considerable amount of clot, so the blood, we have to remove this. Since I am far away from the dome, I can dissect quickly. You see, this is the common trunk of the A1 and A2 on the left side. This is under surface of this is right A2, this is right A1. So I put a temporary clip on the right A1 and then clip the aneurysm. I have to leave enough room for A1, A2, and also this is a common trunk of the left A1, A2. And then removing the temporary clip, but I was not pleased, so I thought I should leave a little bit more space for A1, A2, right, and left A1, A2. So I adjust the clip and then remove the temporary clip. So this is the common trunk of A1, A2 from the left side. I was checking the tip of the clip if has included the whole aneurysm. This is right A2, right A1. This is probably the recurrent artery running backwards towards the anteroperipheral substance. See, this is the right ICA, right optic nerve. The aneurysm is projected anteriorly, inferiorly in between the two optic nerves. And then after maybe 30 seconds, 1 minute, the aneurysm is becoming bluish. So indicating that has been completely occluded and is already thrombosing. This is his postoperative angiography, right ICA, showing the total occlusion of the ACom aneurysm. Here is the a magnified view of this region, ACom region, showing the total occlusion of the aneurysm. This is the lateral projection. You see the clip here. And what happened to him after the surgery? He woke up well from the surgery without neurologic deficits. But 2 days later, he developed right hemiparesis grade 3, mainly right upper limb and aphasia, but the CT showed no abnormalities. So we increased the mean arterial pressure from 103 millimeters of Hg to 125, according to the transcranial Doppler, with total improvement of the hemiparesis and partial improvement of the aphasia. Total regression of the aphasia after raising to 140 millimeters of Hg. 6-month follow-up after the surgery. No neurologic deficit.